Good morning, everybody. As I was telling, opening batsman in the open field, empty field. so, what I'll do in next 8 to 10 minutes is to give a perspective on Axenfeld Rieger anomaly, which is a diverse clinical manifestation spectrum and an individualized and thoughtful approach in the management. So, Axenfeld in the year 1920 presented or reported a case where there was prominent line in the periphery of the cornea in the inner aspect and iris strands bridging the angle to be attached to that prominent Solvay's line. 1930s onwards, similar cases were reported from Rieger, and additional change was there in the form of iris abnormality. So it's a spectrum of disease, Axenfeld anomaly, Rieger's anomaly, Rieger syndrome, when Axenfeld-Rieger syndrome, when associated with non-ocular facial and systemic association. Look at the clinical manifestation of a patient. Actually, this picture is a newborn baby presented with corneal edema, and you can see the anteriorly displaced prominent Solvay's line associated with glaucoma. Glaucoma may be there associated with this condition in up to 50% of the situation, and it can present at birth and from early childhood to adulthood. Here is a patient, extensive iris change in the form of iris hole, ectopia nuvi, correctopia, and associated with dental abnormality, classic manifestation of Axenfeld-Rieger anomaly. The common feature in this kind of cases are usually bilateral involvement, positive family history, there is no gender predilection, frequent association with non-ocular developmental defects, and there is high incidence of secondary glaucoma. You can see here the artist diagram, the structures involved in the manifestation of the disease. Here is a case, typical case of Axenfeld anomaly. You can see iris change, correctopia, ectopia, and UV, and on gonioscopy it is seen that the typical feature, iris strands bridging the angle are to be attached to the prominent Solvay's line. A case where similar feature, but the corneal change is there in the endothelium, extensive change in the corneal endothelium. As I told, about 50% of the patients will be having glaucoma that can manifest at birth or in any time after birth to adulthood. When it is presenting at birth, the typical feature is like primary congenital glaucoma. And if you see carefully, you can see the additional changes or manifestations in the periphery of the cornea, and on gonioscopy, the typical change. The mechanism is, in addition to what happens in primary congenital glaucoma, is the iris strand. The outcome, the surgical outcome, when presenting at birth, usually it's a early surgery required, and surgical outcome is poorer compared to patients with primary congenital glaucoma. Now, Noel Rice in the year 1977 reported a series where 11 cases, 19 eyes underwent goniotomy and associated with extremely poor outcome, to the extent that he commented that goniotomy is probably contraindicated in Axenfeld anomaly, or for that matter Axenfeld-Rieger syndrome. Then what is the other alternative? Other alternative is external trabeculotomy. Compared to goniotomy, external trabeculotomy is probably technically little easier, because when the iris strands are there and associated with corneal edema, goniotomy is technically difficult. In addition to corneal edema or the corneal clouding, precluding good view of the angle, your iris strands come in the way. Compared to that, if you do an external approach, if you can detect the Slem's canal, trabeculotomy can be done, and when you are rotating the trabeculotomy probe, metal probe, probably there will be little stretch on the iridocorneal adhesion, but still you can do the thing probably much more scientifically compared to goniotomy. Here is the situation: trabeculotomy done on either side, then the trabeculectomy part, iridectomy, and then closure of the conjunctival tenon layer. We reported long ago in the year 2016 a series of 44 eyes of 24 consecutive patients in the first 20 years of my work at the L.B. Prasad Eye Institute. Till about 5 years, the success rate was about 93%. And after that, success rate gradually reduced. But one important thing, addition of 1 to 2 anti-glaucoma medication brought the success rate again to a very good or acceptable level. The acceptance is here: if the pressure is controlled with one surgery and then 1 to 2 anti-glaucoma medication, good control, probably that is the way to go, avoiding repeat surgery. But there are situations where patient will require repeat surgery in the form of trabeculectomy with mitomycin or implant surgery. A patient of primary, I'll say, glaucoma at birth, and you can see preoperative and 1 year postoperative appearance. You can see once the corneal edema cleared, prominent Solvay's line is much more clearly seen. The other eye of the same patient, left eye, preoperative and 1 year postoperative appearance. This is 3 years postoperative appearance of the bleb, right eye and left eye. I really do not use mitomycin or any form of antifibrotic therapy in the primary surgery. And here is a situation. I'll give an example in the family how diverse was the situation in the two generations. The boy you see here presented with neonatal onset congenital glaucoma associated with Axenfeld-Rieger anomaly in both eyes. Simultaneous bilateral primary combined trabeculotomy and trabeculectomy was done. Corneal edema cleared, and you can see the left eye enjoying good vision without any spectacle correction for myopia. But unfortunately, after 5 years of follow-up, the right eye was injured severely and we lost the eye. It ended in phthisis. The moment we saw the patient in the clinic, we inquired immediately the mother's eye, having clinical feature typical of Axenfeld-Rieger anomaly. Then I said, is there any other sibling? They said, yes, elder daughter is there. I said, you will be interested in seeing the elder kid. When she came, we saw here typical feature in the periphery of the cornea, and the gonioscopy revealed typical feature, and optic disc was normal. So we followed up the patient, intraocular pressure was normal. After about 13 years, the patient had developed glaucoma, and we did combined trabeculotomy, trabeculectomy respectively in both eyes, right eye followed by left eye. You can see the typical gonio anomaly seen in intersegment OCT, and this is the field defect which is now stable. But look at the mother's cornea. Here is the situation, right eye and left eye. Much more severe intersegment abnormality, but intraocular pressure was normal. There was no disc change or field change, and we followed up this patient for about 20 years. And in spite of extensive gonio anomaly seen here, but in both the eyes, there was no glaucoma. You can see the intersegment OCT. This is the disc change. This is the field, normal, and we are following this patient. So here is a situation. In the same family, the youngest one is presenting with glaucoma at birth in neonatal onset disease. The elder sibling having manifestation at birth, typical clinical feature, but no glaucoma. We detected glaucoma after 13 years of follow-up, and the mother was having similar feature, probably phenotypically, at least intersegment finding-wise, much more advanced change, but there was no glaucoma so far. So disease manifests so varied manifestation, detailed evaluation, thoughtful approach, and individualized decision-making process should be there in this situation. In the when presenting late, maybe medical therapy first, and then the decision when to go for surgery. Thank you.
Thank you, Dr. Mandal. Very insightful talk. Any questions to Dr. Mandal?
I have one question. With the recent advancement
Yes, the question is the way I look at it. Initially, uh, tube implantation should not be the first choice. You mean implant glaucoma drainage device? Yes. Initial surgery, if corneal edema persists, corneal clarity permits, and gonioscopy wise, you can see the change is not very advanced. Probably you can manage with the help of goniotomy. If one is expert in goniotomy, can do that. I have been trained more in the form of an alternative approach because even in advanced glaucoma, even in early form of glaucoma, mild, moderate, severe, the corneal edema is very advanced in Indian scenario. There, goniotomy is technically little difficult. Probably 15-20% of the patients goniotomy will be possible, but a large percentage of patient goniotomy is technically not possible. We do external approach, external trabeculotomy, and in moderate and severe cases, we combine trabeculotomy with trabeculectomy. A dual pathway approach so that the long-term intraocular pressure control is good. The question of implant comes when first surgery fails and then you are adding medical therapy, control is not satisfactory, then the question of implant. I'll say that is the way to go. Susmita, any comment on that?
It's varied, like you say. In India, somehow we are very wary of trying to use the children. And because when we follow them up long enough, invariably they don't seem to do so well. They do seem to rub, or there are more erosions, and so we are very wary of them. So we would go the Dr. Mandal's way of at least trying trab with trab first, but he's right. When we are foolhardy enough to sometimes try a goniotomy or a GAT after pulling down the adhesions, but somehow the Schlem's canal is very gritty. I think Dr. Deepak would be able to explain the pathology of why that is so, but it's very difficult to pass a suture through the angle, and possibly that would explain why goniotomy has such poor results, because I think it's an outflow problem more than in PCG. So what you think the pathology would be?
I'll show you a picture in my talk. So I'll show you a picture. Just two comments. I think the phenomena that you're seeing genetically, where successive children are worse, I think it's not uncommon in ocular genetic disease.
Yeah,
Phenomena
I
is
think
known
that
as,
is the
genetic-
usual way it
genetic
manifests.
anticipation. This is what the penetrance increases
Yeah.
with successive children. I think, Murali, you have seen this in a
Yes.
family. PPMD, correct? The very similar manifestation. And we see this in congenital glaucoma as well, that there seems to be a gain in penetrance with time.
Is there a reason, sir?
It, yes. The other comment I wanted to make about is the term post-GI ambryotoxin. So, I think we've shown both, and it's in your picture as well, that it really is not Schwalbe's line.
Yeah,
It really is
yeah.
a nub
I
of,
know, I
a
know.
nub of cornea that indents decimates, and most often it's not at Schwalbe's line.
Mhm.
It's in other locations, more of a semantic thing, but that's the definition.
Yeah, I am aware of your publication. Excellent publication. Thank you.